So good evening, everyone. We are moving into the second day of the ASI Time for this year. I request Dr. Maruthapandian, our President, to say the introductory comments.
Good evening, all. Respected Vice President Dr. Pratap Parute, Honorary Secretary Dr. Hadi Diwakar, Treasurer Madam Madhumita, Academic Director Dr. Rajgopal Sanai, Past President and Advisor to ASI Dr. Santosh Sir, our Past President and Social Welfare Council Director Dr. Siddesh, and all the faculty members, the moderator Dr. Pramod Sinde, faculties Dr. Rajesh, Dr. Sharad, and Dr. Kanagavel, and dear delegates. Really, I'm so happy to have this topic to be discussed in detail regarding the abdominal wall closure, starting from simple, straightforward cases to the complicated cases. I'm happy to note that there are some videos also which will be much useful for the younger surgeons to catch up these points. Once again, I thank all the faculty members for having accepted to participate in this program. With these few words, I request our director and as well as advisor to proceed further. Thank you, sir.
Thank you, Professor Maruthapandian. I request Dr. Varate, our Vice President, to say a few words.
Thank you very much, Santosh sir. Respected President ASI, Dr. Maruthapandian, Secretary Dr. Gatti Diwakar, Treasurer Dr. Madhumita Mukhopadhyay, Director Academic Council, Professor Dr. Rajgopal Sanai sir, Director Social Welfare Council, Past President ASI Dr. G. Siddesh, Chief Architect of ASI Academics, Advisor to ASI AC and Past President ASI Dr. Santosh John Abraham sir. It gives me an immense pleasure today to welcome all the esteemed panel for the second episode of ASI Time, which is dedicated to the ever-evolving field of abdominal wall reconstruction, with the panelists being Dr. Sharad Sharma from Mumbai, Dr. Rajesh Gopal from Kozhikode, Dr. Rajesh Srivastav from Bhilad, and Dr. Kanagvel from Chennai. And moreover, the icing on the cake, being the entire session, will be moderated by one of the pioneers of AWR community in India, Dr. Pramod Sinde sir. I am confident that today's deliberations will be academically stimulating and practically relevant to all the viewers on this YouTube channel. I wish the entire panel a very successful and productive hour ahead. Thank you very much, sir.
Thank you, sir. Dr. Rajgopal Sanai, sir, please.
Good evening, sirs. The most respected President of the ASI, Dr. Maruthapandian, Dr. Vice President, Dr. Pratap Parute, sir. Then Dr. Diwakar Gatti, National Secretary, our Social Welfare Council Chairman and Past President, Dr. Siddesh, Treasurer Dr. Madhumita Mukhopadhyay, and all eminent speakers, abdominal wall hernias. And today, especially, that this topic is such a fascinating one. So many problems which we still face, and this will be definitely a great boon to everyone, whether it's a postgraduate or surgeons or senior surgeons or anyone for that matter. And I hope this will come out excellently. ASI Time. This is our second week actually. We are in the process of having excellent teaching programs, rather the programs of the ASI. So with this small welcome, every one of you, sir, and waiting for a excellent, the show. Thank you, sir.
Thank you very much. I request Dr. Pramod Sinde to take over the mantle and proceed with the proceedings. Dr. Sinde, please.
Thank you, Dr. Santosh John, sir. Thank you, President, sir. our academic director, Dr. Raj Gopal, and all the dignitaries from the ASI. It's indeed a pleasure and honor to be hosting this webinar especially with our esteemed panelists today. So we will be having 4 talks in this, and the whole focus will be on different aspects of the abdominal wall reconstruction, how it is done, and obviously it will start with what is it and why so. So I will start with a short introduction to this abdominal wall reconstruction and component separation. And then our esteemed panelists will talk one by one, and at the end of my presentation, I'll also outline the program. So what is the basis of abdominal wall reconstruction? It is basically a technique and science to restore the anatomical and physiological function and integrity of the abdominal wall. So actually, abdominal wall behaves and is in fact is a cylinder. It functions as a cylinder. It has got multiple components and functions, and all or any of its functions are affected by the integrity of it as a cylinder. So we all know that abdominal wall has got a great role to play in the Valsalva. It supports all organs, it supports spine, and it acts to raise IAP during Valsalva maneuvers. And whenever a large hernia like this disrupts the cylinder that the abdominal is, massive hernia like this results in loss of support to the organs, loss of support to the spine, their lumbar lordosis aggravates, there's backache, loss of satiety, loss of effective Valsalva required for defecation, cuffing, micturition, and even parturition. Not only that, the lateral muscles actually contract after a midline large defect of hernia. And not only do they contract, there is a fibroblast proliferation, there is a collagen contraction function, and they in fact become rigid and they become less compliant. So if you look at this CT scan of a massive hernia with loss of domain, you'll see that it is not just a wide defect, but these lateral abdominal walls are not only retracted, but they are contracted. So it's not just that we can pull them together and close the defect. They will not come easily because they have become more rigid and less compliant. So hernia disrupts the integrity of the cylinder in many ways: anatomical, pathophysiological, functional, the muscle function, supportive function, and there is an evidence that reconstruction of the linea alba in laparoscopic incisional hernia, or any hernia repair for that matter, improves the functionality of the abdominal wall. Also, primary facial closure with mesh repair is superior to just a bridged mesh repair, as is seen in this paper, that a bridged repair where you don't close the midline or the defect, this is independently predictive of developing a very high incidence of hernia recurrence. And we should avoid bridged repairs for as far as possible. But when it comes to complex hernias like this, with massive hernias, loss of domain, then these complex hernias need something more than just closure of the defect, which will not be possible, and more than something like just a simple mesh repair. So why is component separation necessary? First of all, in order to pull those edges together and close defects larger than 6 to 8 centimeters, to restore the anatomic and functional integrity of the broken cylinder, to create a space for a large mesh to overlap, as we'll see in our forthcoming lectures, that component separation is also necessary to create a large space to place a larger mesh for these large hernias. Sometimes for lateral hernias, as we'll be seeing in Dr. Rajesh's talk, if we need to access the lateral compartment, we need a component separation. So now the first component separation was really described by Albanese way back in 1951, but it was really popularized by Ramirez in 1990. And this then became and came to be known as the anterior component separation. Posterior component separation was first described by Carbonell, but really Yuri Nowitzki changed the entire scenario of the world when he described the TAR in 2012, and today it has revolutionized abdominal wall reconstruction and forms the mainstay, and this we will be covered seeing Dr. Sharat Sharma talk about this. So where is abdominal wall reconstruction really headed? So we are seeing more and more complex patients. The repairs are becoming increasingly complex. Surgeons are invading every possible plane, as you will see in some of our talks. More skills are needed, more training is needed, technology is booming and growing by the minute. In fact, then that leads to even more complications, and these complications also can be dreadful. And obviously, there is much more social media involvement than ever before so far. So today, our webinar will be having of 4 topics. The first, it will be led by the first topic by Dr. Sharat Sharma, who is the current president of the Abdominal Wall Reconstruction Surgeons Community, and he's an AWR laparoscopic robotic hernia and bariatric surgeon at Navi Mumbai. And he is going to be speaking on what is abdominal wall reconstruction and the role of TAR, focusing mainly on TAR. Then the second talk will be given by Dr. Ajesh Gopal from Kozhikode, who's an excellent laparoscopic MIS surgeon, and he'll be speaking on extraperitoneal repairs for midline ventral hernias. Dr. Rajesh Srivastav is an international faculty, once again coming from Bhilad, Vapi, Gujarat, and has played a very active role in the ASI chapter there. And he will be got some presentations and many publications also. He'll be speaking on lateral hernia repair difficulties and technique. And the last talk will be given by the one and only academic brain that we all know, Dr. M. Kanagvel from Chennai. And he'll be speaking on fasciotens, the new armamentarium for loss of domain hernias and even other hernias which are large, where fasciotens can be used to restore the integrity of the abdominal wall and this cylinder. So with this short introduction, I request our president of the Abdominal Wall Reconstruction Surgeons Community, Dr. Sharat Sharma, to take over and start his first talk on the role of TAR. Thank you.
Good evening, and thank you for inviting me. I'm sharing my screen. I hope you can see it.
Coming up, sir.
Yes, sir.
Thank you. Thank you very much. So, Dr. Shinde, thank you for making my life easier. I think whatever you have told is of great importance, and it is very relevant to what I'm going to speak. So my topic would be abdominal wall repair and the role of TAR, that is the transversus abdominis release. But why are we discussing all this? What is the need to talk about abdominal wall in such a fashion? Because for decades, a hernia has been just a hernia. But I think our experiences with recurrences and with the humongous size of hernias that we see, we realize that abdominal wall is a complex structure. It is a complex layered structure, not just a single brick of muscle. And it also has a unique role with the core group of muscles. So it acts together with the core group, as Dr. Shinde has told us. Unfortunately, abdomen is the most, the structure which has been violated the most by us, and all our incisions or even spontaneous hernias or incisional hernias, they occur in the abdomen. If you look at this carefully, if you look at this diagram carefully, none of the incisions, or most of the incisions rather, are violating the abdominal musculature and their neurovascular supplies. And this is the reason why we have so many incisional hernias. And given with that, we also have spontaneous hernias, which can be pretty large. So hernias as such is quite an important subject for us general surgeons. Now, understanding abdominal wall repair is important, because if we do not know where the muscles and aponeurosis appear and what are their attachments and courses, or what are their neurovascular supply, it is very difficult to make a very functional anatomical repair of the abdominal wall. We also have to lay large meshes. So we know that recurrences reduce when you use mesh. Now, laying these large meshes involve creating spaces. So again, the knowledge of abdominal wall and dissection of the abdominal wall into functional compartments help us in putting large meshes. We also know that unless a muscle is attached at the insertion and the origin, you do not get a physiological tension. Now, if you see that all tendons and muscles are repaired primarily, but unfortunately, many a times, or even, as the previous practice, we had done bridging repairs. Now, bridging repairs is definitely not a functional repair. So abdominal wall repair as of today is being bridged, is conceptualized as non-bridging repairs or a primary functional repair. Coming to complex hernias, where you can see large hernias with defects more than 10 centimeters up to 20-25 centimeters. Now, when you talk of repairing these hernias, it is very difficult to repair them by simply suturing and putting a mesh. They require specialized methods so that you can create spaces, suture the defects, and put large meshes. Now, the aim, as Dr. Shinde has already mentioned, is to facilitate the closure of the hernial defect. So the hernial defect has to be closed. All the tendinous structures have to be brought back into the midline and recreated. Large spaces have to be created so that we can put a large mesh. And at the end of it, what we create is a functional abdominal wall with very low recurrences of the hernia. Now, component separation has been described over the years in various manners, that is the anterior component separation and posterior component separation. And as Dr. Shinde has already mentioned, most of the muscles by various authors have been incised and dissected so as to create a kind of a slide between the muscle groups so that the defect can be closed and spaces can be created. But it was Yuri Novitsky in 2012 who described something called the transversus abdominis release. And to understand this concept of transversus abdominis release, what we should know is that we enter the Reeves Stopa space. So the Reeves Stopa space is entered, that is behind the rectus muscle on both sides. So on the right side as well as the left side, we dissect the Reeves Stopa space. After doing that, we incise the transversus abdominis muscle, and that is done medial to the neurovascular bundle, which we will see gradually. Once that is done, we again enter the preperitoneal space. Now, this whole space, starting from the Reeves Stopa space to the lateral preperitoneal spaces, we create a large area which can accommodate even up to 50 by 50 centimeter mesh. And with this, we can close large defects. So we have mobilization of the muscle as much as 8 to 12 centimeters on either side, which enables us to primarily close large defects as much as 20 to 25 centimeters. So all the evidence that has been created or evidence that has been collected in favor of transversus abdominis release, showing that large amount of dissection can be done and mobilization of muscle to close huge defects is possible. The idea is to do a transversus abdominis release, but we should also know that Reeves Stopa by itself is a good operation. But Reeves Stopa has its own limitation because the space of Reeves Stopa is just the space behind the rectus abdominis muscle. But in case we are unable to complete a surgery or do a hernia surgery by Reeves Stopa, we will have to proceed to a TAR. But this needs to be understood in the sense that we need some kind of indicators which suggest preoperatively. So we need to plan these complex operations where preoperatively we should be able to understand that this patient is going to be requiring a TAR instead of a Reeves Stopa. So one of the indices is called the Carbonell's algorithm, where if you see here in the CT scan, the defect width, and we also measure both the rectus width. So the defect width has to be twice the size of both the rectus width added. So if you multiply the defect width by 2 and then you divide it by the width of both the recti, the figure should be more than 2. In that case, you can complete it with Reeves Stopa. In case it is less than 2, if the index is less than 2, then you will require to do a TAR. Second is the mesh to defect area ratio. In case your mesh to defect area ratio is inadequate, that means your mesh is going to be of a smaller size, then you have to do a transversus abdominis release so that your mesh can be a larger mesh and you can reach a mesh to defect area ratio of more than 13. Also, you have the Slater's paper suggesting that a defect width of more than 8 centimeters or a hernia area of more than 164 centimeters square is a hernia which will most probably require a complex posterior or some kind of a component separation to repair the defect. Incidentally, it so happens that you end up or you start with a reef stopa without much of a planning, but then what you see is you are unable to achieve a midline closure, or your mesh is small and you are unable to put a larger mesh in the rectus, or you have seen that there is an atrophy of one or more groups of muscles, that is the rectus muscle, so you do not have the mesh which gives enough strength to the narrow strip of posterior rectus sheath. Also, you may find that the abdominal wall may be stiff, as Dr. Shinde has said. They can become stiff and non-compliant. In that case, even if your muscle width is good, you are unable to close abdominal wall in midline. In all these cases, again, you have to, start doing a TAR procedure so that you can draw the muscles into midline and you can put a larger mesh. TAR is a complex operation which requires a good patient optimization. So you have to plan these operations well. You have to see that the patient diabetes status is controlled, HbA1c is reduced to close to 7, patient stops smoking, weight maintenance is important. So if patient is of BMI more than 35 or more than 40, we need to reduce the weight. Patient has to make an effort. And if the muscle defect is too large, that is, it is more than 20 centimeters or more than 15 to 20 centimeters, you may require, or with a non-compliant abdominal wall, you will require something like the Botox injection so that your muscles can become compliant. Now, when we do a TAR, we must understand that we start this by doing a posterior component, a posterior rectus sheath incision. So in the classical TAR, you have the muscle in the upper 1/3. So you have the muscle in the upper 1/3, which is incised. And this is incised after incising the posterior lamella of internal oblique. You have a classical posterior lamella of internal oblique. Once you incise that in the upper 1/3, you will see that you have the transversus abdominis muscle. Transversus abdominis muscle. And then you incise the transversus abdominis muscle. So posterior lamella of internal oblique muscle incision is a very important aspect of the TAR dissection. And this contributes significantly to the sliding of the muscle. So whenever you are doing a posterior component separation, see to it that the posterior lamella of internal oblique, that is this whitish aponeurotic structure, is incised and the transversus abdominis muscle is exposed well before you start the TAR procedure. Now, a classical TAR is started in the upper 1/3. So if you see here, we enter in the upper 1/3. This is a laparoscopic view, but still you will be able to see it. And then what you do is you see the posterior rectus sheath. So here you have the tunnel of the posterior rectus sheath. And in the lateral aspect, you will see something called the neurovascular bundle. So whenever you are doing a TAR procedure, you will be incising the posterior rectus sheath 1 centimeter or at least 0.5 centimeters medial to the neurovascular bundle. Now, this is a very important step when you are doing a TAR so that you have a functional rectus abdominis muscle. Whenever you are doing a bottoms up TAR, so when you do a TAR which starts from below, you start from the arcuate line. So you mobilize the peritoneum below the arcuate line and you start incising, and this TAR is called the bottoms up TAR. You can see classically, you can see here. So the arcuate line is mobilized and you start incising the TAR plane from below upwards. What we have to absolutely not do is incise the linea semillunaris. So you are not supposed to injure the neurovascular bundle. So the Carbonell had started the posterior component separation and he used to incise the neurovascular, he used to sacrifice the neurovascular bundle and incise the posterior lamellae going into between the internal oblique and the transversus abdominis muscle. Now that is a wrong plane. It is actually a tap plane where you also damage the neurovascular bundle further ahead. Whereas the TAR plane is actually pre-peritoneal after incising the transversus abdominis muscle. Now, when you incise the transversus abdominis muscle, you must understand that superiorly, this muscle interdigitates with the diaphragm. So when it interdigitates the diaphragm, whenever you are incising this muscle, superiorly, you may end up incising the diaphragmatic muscles also. Once you do that, you end up creating a hernia called the Morgagini's hernia. So you have to see that transversus abdominis muscle is a horizontal muscle. The moment you start seeing vertical fibers, you know that you are crisscrossing with the diaphragm. At that point, you have to be strictly preperitoneal. So in the upper part, the diaphragmatic area has to be seen. So here you can see in the upper part, whenever you are incising, the diaphragm is also interdigitating. And here you see classically, this is the incision of the fleshy part of the transversus abdominis muscle. And as you go below, this fleshy part becomes aponeurotic. Completion of TAR is very important. So in the upper part, the TAR, you have to see the central tendon of the diaphragm. Inferiorly, you have to see the spaces of the Bogros and Ritzius completely dissected. And laterally, you have to go up to the psoas and the gyrotas fascia. For this, you use the transversalis fascia and you go all along it. So the transversalis fascia in anteriorly, it goes upper part, it will be the inferior fascia of the diaphragm. Laterally, it is the fascia of the quadratus lumborum. Inferiorly, it will be the obturator fascia, and the posteriorly, it will be the superior fascia of the pelvic diaphragm. So unless you incise all these transversalis fascia layers, you will not be able to complete a TAR procedure. The culmination of the TAR is ultimately about connecting the potential spaces. And what are these spaces? These spaces are the subxiphoid space, the retrorectus space, the pretransversalis and the preperitoneal space, the subdiaphragmatic, and the space of the Ritzius and Bogros. In the end, what you do is you create a large space where you can repair the muscle as well as put a large mesh. If we have time, I can show you this small video of an ETEP reef stopper. That is a laparoscopic video. This is a 10 centimeter defect. This is completed with 5 ports, and the entry is by optical method. You can see the anterior sheath, rectus muscle, and the posterior sheath. Once you enter, we start the pneumoperitoneum, and this is the retrorectus tunnel. This is the left-sided rectus muscle at the roof, and laterally you have 2 more ports. After this, we start the dissection and do a crossover. Now I am performing something called the crossover by dividing the medial border of the posterior rectus sheath. The fat that is protruding here is the falciform pad of fat. Now I'll be enlarging this and doing something called the crossover. Now what I see here is the posterior rectus sheath of the right side. And I have incised this posterior rectus sheath entering into the retrorectus area of the right side. Once that is done, another port is inserted and we start dissection of both the retrorectus spaces as well as the hernia. All the time you will be seeing that we have something called the lamppost sign, which are the neurovascular bundle. And now you see the fleshy part of the transversus abdominis muscle, which is in the upper 1/3. Once that is done, we go towards the hernial sac. This is a recurrent hernia. You will see the mesh, you will see the sutures, and now the whole hernial defect is dissected out. It is a pretty large defect along with the scar, the weak scar, and the diastasis. Be careful when you are doing this dissection. You have to see that you do not create any bowel injury. All the adhesiolisis has to be done carefully. So this was an onlay mesh, and you can see the entire mesh exposed. Now we complete the retrorectus dissection into the pelvis. And this is the left-sided dissection. So and you can see the inferior epigastric artery now. So the complete dissection of the spaces of the Bogros and the Ritzius is important. Now I start the transversus abdominis release on the right side. So I'm incising the posterior lamellae of the internal oblique, which is a whitish aponeurotic structure, below which is the transversus abdominis muscle, the fleshy part. Now that is being incised again. So you can see there is a good amount of release that is happening. Once this is continued, you will see that the transversus abdominis muscle becomes aponeurotic. So as you keep going down, the muscle becomes aponeurotic. Now I proceed doing the same thing on the left side. So I'm proceeding to do this transversus release on the left side. And now I'm completing the dissection laterally. So the preperitoneal dissection is completed laterally as far as the gyrotas fascia and the psoas. Now I'm measuring the defect. So it is good 15 by 8 centimeters defect. The closure of the posterior rectus sheath is done. Complete closure. Once the posterior rectus sheath is, and you need to close all the defects. So all defects in the peritoneum have to be closed so that the muscle remains preperitoneal. Now I proceed to doing the closure of the hernial defect. The hernial defect is closed with a PDS. And the final closure is done. So you can see here, complete closure of the hernial defect is done. So this is the final view, that is the right rectus, left rectus, complete closure, and a large mesh of 30 by 30 size is inserted and fixed. I would keep a drain here to be careful, but otherwise nowadays we have stopped putting a drain. So thank you. TAR enables dissection in correct plane. It allows us to preserve the neurovascular supply. It allows us to place a large mesh in the sublay space. And we end up performing a physiological, functional abdominal wall repair. This helps us improve the quality of life and reduce the recurrences in future. Thank you very much.
Thank you, Dr. Sharad Sharma, sir. We will be taking questions at the end of this sessions. So thank you for a very good exposition of not only just the technique of TAR, but why it is needed, where it is needed, and what are the markers where you know that you will be needing a component separation. So we will come back to you with the question and answer session. So the next talk will be delivered by Dr. Ajesh Gopal from Kozhikode, and he'll be talking about the extraperitoneal repairs or the MIS repairs in midline ventral hernias. So Dr. Ajesh Gopal.
You're muted, sir. Professor Ajesh, you're muted.
Dr. Rajesh Gopal, I think his sound is muted. He's from Malabar Medical College, Calicut. Dr. Ajesh, can you hear us?
Yes, sir. Yes, sir.
So please go ahead.
Thank you, sir. Thank you, ASI leadership. Am I audible now?
Very
Yes,
much.
yes.
Yeah, thank you, sir. Without further ado, let me start with this. When it comes to MIS extraperitoneal procedures for ventral hernia repair, the fastest growing technique is enhanced view totally extraperitoneal Reustopa technique. There have been a recent interest in preperitoneal ETUP or PETUP. The PETUP minimizes the extensive dissection in various planes and negates the step of PRS division and crossover. It is more of a targeted dissection specifically designed for the small primary midline ventral hernias. Simultaneously, inguinal hernias and ventral hernias can be repaired by the PETUP as well. Relatively, the access is simpler, encouraging wide range of surgeons to perform the PETUP. However, it is specifically suitable for the primary midline ventral hernias. This brief presentation is intended to focus more on the ETP Reustopa that addresses wide range of ventral hernias. This has been already discussed by our previous speakers, Shinde sir and Dr. Sharath. So in 2025, it is considered, the ETUP-RS is considered as one of the gold standard techniques for MIS procedures for ventral hernias. So when we consider ETUP or even PETUP, most of the midline hernias can be addressed by the ETUP, ETP Reustopa, subxiphoid M1 hernias, lateral hernias, ETUP RS, rectus diastasis, ventral width inguinals, again ETUP RS. Among these, only the lateral hernias are an exception for the, probably an exception for the PETUP, whereas all these hernias can be addressed effectively by the technique ETP Reustopa. As it has been already mentioned, in our institution, our practice is, our preference is to do ETP Reustopa from 4 centimeters to 10 centimeter size hernias. The table position is like this. These basics have already been explained. This is a crossover, the standard. We proceed with a, usually we proceed with a only lateral 3 ports technique, that is a phytid trident. The anatomical considerations have already been mentioned. So this is a novel anatomical consideration when it comes to port placement. The lateral border of the rectus sheath, all the ports have to be medial to the EIT ambivium, that is the lateral border of the rectus sheath, where all the 3 muscles, all the lateral muscles converges and forms the lateral border of the rectus sheath. Whereas the linea similaris is a curved line. This has been recently published in the JIWS journal. It's a curved line that represents the transition point between the muscular and aponeurotic parts of the transverse abdominis muscle. So the linea similaris and EIT ambivium are slightly different, and this area between the linea similaris and the EIT ambivium is called the Spigelian fascia. And for the youngsters, they may take a note that the Spigelian hernia comes out through the Spigelian fascia. The point here to be made is all the ports have to be medial to the EIT ambivium or the lateral border of the rectus sheath. So here, this is the depiction. It's already shown in the procedure. All the neurovascular bundles come between the internal oblique and the transverse abdominis. So this is the peritoneum. This is the pre-peritoneal plane, and this is the Reustopa plane, or the Reus plane above the level of the arcuate line. The position and approach, our approach is typically lateral 3 ports. We don't use the opposite side in most of our cases. We don't use the right retrorectus plane dissection in most of our cases. Lateral 3 ports that we use to cover all the midline and most of the lateral hernias, including our M1 hernias in many of the cases. So 10 mm port, the second port is 5 mm, and third port is again a 10 mm port, which switches downwards for the further dissection after creation of the retrorectus space. For the crossover, we typically use the lower 10 mm port. Again, this is the retrorectus area. That is the PRS on the left side. It's already been discussed. Why ETUP? The retrorectus plane is considered to be one excellent plane for the mesh to be placed, which is vascular, and the pressure dynamics is favorable. The mesh is secure between the muscle and the PRS. The mesh integration is better. It is certain, in some studies, it has been mentioned that the type 1 collagen, the ratio between the type 1 and type 3 collagen is better, and better vascularization is also there. The polypropylene mesh in the Reustopa plane translates to a lower cost compared to the intraperitoneal procedures like IPOM. The best barrier between the mesh and viscera is obviously the patient's own tissues, that is the peritoneum or the posterior rectus sheath. Obviously, it can be used for closure of wide range of defects in different situations like lateral and midline. So this is just a video of the left retrorectus dissection. Some of these have already been shown by our fellow panelists. So this is the lateral 3-port approach, a slight difference from the previously shown video. These are the perforating vessels. This is the inferior epigastric artery. These are again the neurovascular bundles. There are T7 to T11 and the subcostal T12. All these come and supply the rectus muscle. That is the Lampos sign again, the superior epigastric, the inferior epigastric. This is the arcuate line. The beginners may take a note of this. All the ports are placed medial to the AIT ambivium, or the lateral border of the rectus sheath, and it is medial to the inferior epigastric vessel. So a guideline needle can be used for initial few cases. This roughly corresponds to the AT ambivium and the linea seminonaris. This is the arcuate line. That is a retrorectus plane creation. That is the left PRS. And subsequent ports are placed as shown in the previous picture. Now there are some vessels. These are some crossing vessels called bricks vessels, which can be injured during the dissection, but that can be cauterized easily to avoid any bleeding. Now the dissection switches to the upper part, the xiphoid area, towards the xiphoid area with telescopic dissection on the left side itself. And one can see the T7, T8 neurovascular bundles comes there. This is again the left upper part of the retrorectus dissection, that is towards the left costal margin, the same side. And similarly, we continue with the crossover. 5 millimeters from the seam of the left PRS to the linea alba, 5 millimeter. So that continues. I'll just fast forward the video. And at some point of time, you reach the marshmallow sign, which is a brownish color of right rectus seen through the right PRS. That is the marshmallow sign where you can put the incision like this. This is the cut edge of the other PRS. Already there is a wrench. This wrench you can utilize for peeping into the peritoneal cavity as to what is happening inside. Is there a bowel, or if there's a snake behind the bushes? Now, the same procedure in a different case. The scenario is same. Continue with the crossover to the opposite side. That is the marshmallow sign again. The crossover and the right retrorectus plane creation is being done. That is a perforating vessel. One should not confuse this with the neurovascular bundle. The perforator small vessels can be cauterized when required, but not the neurovascular bundles. So now I will fast forward this. So this is the cut edge of the right PRS, that is that of the left PRS. And the dissection continues that is the NVB on the right side. Dissection continues, and the sac dissection, peritoneal preservation as much as possible is done. This is a midline hernia, it's a recurrent midline hernia, which is a Swiss cheese defect. And the same procedure continues. As far as possible, the sac is preserved. I'll just fast forward for the want of time. And this is the outer view of the large hernia. Only 3 ports are being used. That is the closure with a stratafix or a V-lock or a true barb as per the availability in your OT, and a large mesh can be placed. We don't routinely use a drain. So in upper part, if there are multiple scars or previous hernias, upper midline scars or lateral scars, you can use an inferior crossover where you start the retrorectus plane creation here and put 3 ports downwards, make a crossover here and approach upwards. This is just one option. For beginners, there is a tip for the beginners. If they find it difficult to make the crossover in the midline, after creation of the left retrorectus space, one can access a right retrorectus area, just like what we did on the opposite side, and create some space here and show the telescope towards the opposite side, and thereby cutting exactly the right PRS. That is one of the tips we advise for the youngsters. This is a word about Carolina crossover, just for completion's sake. So here we don't cut the opposite PRS. We cut the left PRS, and the mesh is placed in a retrorectus plane on the left side, but a preperitoneal plane on the opposite side. So this is how it is done. The falciform is depressed, and the further dissection continues in the preperitoneal plane. So first half it is retrorectus, and the second half it is preperitoneal. That is also a helpful method for beginners to start with. A word about the P-ETUP, as I have already mentioned, midline small-sized hernias, P-ETUP is an excellent tool. So this is again the fatty trident. For the superior approach or the cranial P-ETUP, one can use the subxiphoid fatty area or the falciform. One can easily create a preperitoneal space there, then continue downwards towards the space of Retzius. These are the lateral two prongs. Here also the dissection is relatively easier, but this area, one has to jump one plane up towards the pre-transversalis plane to continue with the P-ETUP. This is a slight modification of even the P-ETUP. That is a Madrid-Rives modification put forward by the Madrid group. Here it is the upper approach, the cranial approach, and two lateral ports. Then this space is created. Then divide the PRS on both sides transversely and then go downwards vertically, just like in ETUP. So this can address midline hernias and some of the lateral hernias or even inguinal hernias by putting two ports at this suprapubic area. So that is a word about the Madrid-Rives crossover. ETUP advantages, the risk of adhesions is less because we are basically operating in a plane which is not in connection with the intestines. Mesh infection rate is lower because of the lesser contact with the viscera. Chance of visceral injury is less. Recurrence rate is lower in most of the meta-analysis studies that have been published. Midline linear alba reconstruction provides superior functionality and core muscle integrity, improved posture, larger mesh as per the mesh defect area ratio, at least 12 to 16 ratio of 12 to 16 can be provided. Postoperative pain and chronic pain are comparatively lesser compared to the intraperitoneal or IPM procedures. Length of stay, hospital stay is significantly lesser. These are all in favor of ETUP. These are all meta-analysis studies from various countries. The incidence of seroma is less, hematoma, SSI, SSO, skin necrosis, prolonged ileus, bowel adhesions, obstruction, respiratory and cardiovascular complications, conversion to open, readmission, recurrence and mortality rates have been mentioned as lesser in the ETUP arm. This is the same postoperative scenarios. Everything shows a better outcome in ETUP arm. It is an excellent tool. ETUP is an excellent tool to address the rectus diastasis, whether it is D1, D2, or D3. This is the EHS classification for rectus diastasis. This is a short video. I will quickly play this one also if the time permits. Another patient with a rectus diastasis. The crossover is being done. I'll fast forward this one. And that is the retrorectus plane being created. So this is the large divarication to the tunes of 10 to 12 centimeters. As far as possible, the peritoneum is preserved. That is the way to go. Now the defect is shown here. So ETUP or even PTUP can treat midline divarications to a larger extent. The closure is done with, again, a true barb or a stratafix. A little bit of backhand suturing is definitely handy in addressing such defects. I'll make it fast. So the entire midline reconstruction and obliteration of the sac is being done. And again, a larger mesh is accommodated. Alternative MIS procedures. This is a patient who is a national level bodybuilder who came with a M3W1 hernia. So I didn't want to cut his PRS. So I opted for actually a ventral TAPP. So there are some set of patients where the falciform ligament is super thin or non-existent. This is just a band. Instead of falciform, there is a band. So the upper crossover is difficult in this case. That's the postoperative outcome. So P-ETUP and ventral TAPP are other tools to address similar scenarios. When ETUP-RS is sufficient or insufficient, when to add a PCS, this part is already discussed. Now here, this is when one would normally switch to a unilateral TAR or a bilateral TAR. This is a bottoms up TAR in this case. So that part is already been discussed already. So I am not going to those details. I will just fast forward this one.
I think we are done.
Yeah. Yes,
Very
sir.
sure.
Right. Now, ETA specific concerns. These are the last couple of slides. The PRS disruption is an ETUP specific concern, which P-ETUP can avoid this type of postoperative scenarios. Immediately take a CT scan and reduction of the bowel. A composite mesh or absorbable mesh can be used in such scenarios. This for the beginners, this can happen, a linea alba injury. So one can avoid the linea alba injury by switching to a slightly lateral. This is a linea alba injury. So immediately found this and the incision is further lateralized and switched and the proper plane is achieved. So this can be avoided. So ICG can show the marshmallow sign in a better way in such cases. So this part is already discussed, the requirement of component separation. So these are my conclusions, which is already discussed. Thank you, sir. Thank you. Thank you, ASI leadership, for this opportunity once again. If there are any questions, I will be happy to take when it is the time for that.
Thank you, Dr. Ajish. The figures were wonderful. And we'll come back for the question and answer session later. So I would request Dr. Rajesh Srivastav to deliver his talk on lateral hernia repair, the difficulties and the technique for lateral hernias.
Sir, am I audible?
Yes, you are.
So the topic given to, thank you, Sindhu sir, and all the ASI dignitaries for giving this honor for speaking for this important topic, that is lateral hernia. Difficulties and technique. I will try to touch at least all the technique which are possible in lateral hernias. So EHS classify L1, L2, L3, and L4 as a lateral hernia. L1 is subcostal, L2 is flank, L3 is iliac, and L4 is lumbar. So this line is very important, as previous speakers have beautifully described by described TAR. It will come this procedure later on. So these are the primary lumbar hernias, and we know that this is superior lumbar triangle and this is inferior lumbar triangle. So I am not good in anatomy because we all know that. In the interest of time, I'll just leave it. But most of the lumbar hernias are difficult hernias because usually what we get in practice is incisional hernia after renal transplant, after pilocytomy, or other traumatic incisions. So why the lateral hernia is different? Number one, anatomical location. When we have seen in previous talks, the abdomen ventral hernias are flat. When we go laterally, it is a curvature. It is a curve. Then neurovascular complexity. When you come from above down, there are intercostal nerves, there are subcostal nerves, there are retroperitoneal nerves, and we go in cave of Bogras, we know multiple nerves which we see day in out in inguinal hernia. So multiple nerves are there in lateral area. Challenging mesh placement. When we have seen that when you are in midline, you have to place a flat mesh, maybe 30 by 30. But when you are lateral, it's a curve. So placing a mesh is very difficult, and that too fixation of mesh is more difficult because there, there are multiple nerves and fixation over the nerves is very difficult. So what is the trick? In lateral hernias, you more lateralize the defect and go more lateral with your mesh. Means more coverage of mesh is required than in midline hernias. Causes and risk factors. These all hernias we see after liver transplant, after renal transplant, our hepatic malignancy surgery, after nephrectomies. These all patients have comorbidities and they all create a surgeon to stabilize them and operate. Diagnostic challenges, again, when we see, many of the times we see there is a huge bulge. But when you see this bulge is because of nerve injury, not because of hernia. So the symptom of lateral hernia is very variable. For a small hernia, the patient might have severe pain, and sometimes patient have a large bulge without hernia. So diagnostic challenge is again a very important. Higher risk of chronic pain. We know that multiple nerves, so more chances of pain. Complex surgical approach. We will see what approaches we can have in lateral hernias. Of course, when the repair is difficult, the recurrence is, chances of recurrence is more. And finally, it needs some multidisciplinary care because these are not the hernias which a beginner should try. So mandatory investigation, CT scan, I will just leave that, beautifully explained by previous speaker. This is the fatty plane, then retrorectus plane, and then TAR plane. So this is the area of lateral. Orange is our area of lateral hernia. So whenever you want to approach in that area, in most of the cases, you will need some myofascial release that to be might be TAR. So neurovascular bundle has been spoken by speakers. So as younger surgeons are there, I just want to show them because now with ICG, we can very well demarcate these neurovascular bundle. So it is inferior gastric artery. This is inferior gastric artery of left side. Now we have given ICG. And beautifully, you can see it glows like a bulb. So before going lateral, you should know the anatomy of these neurovascular bundle. And without knowledge of this, you are not supposed to enter into the lateral space for the lateral hernia repair. So now this has been explained. I will just skip that. Now, so what are the techniques which are possible? Now, this is the technique which is usually earlier, before TAR and before the era of ETEP, this was the only MIS technique which we used to use. This is subcostal hernia. IPOM is not my personal choice nowadays for these lateral hernias, but yes, for subcostal hernia and L2 hernias. You can use IPOM because when you go laterally, more laterally, you can do tape. Tape means you have to mobilize the colon and then push the composite mesh laterally and then fix the composite mesh medially. But to me, IPOM is not a good technique for lateral hernia repair. So now this is the patient, 52 years patient, and he was having post-appendectomy burst abdomen. And you will see this was the large hernia. So in this patient for lateral hernia, you need not to do a crossover, which has been shown by the previous speaker. All your 3 ports are on one side. Now this is the first port and first secondary port, and this is second secondary port. You have seen that we have not crossed the linea alpha. We are on one side, and then what is required is this is the TAR which we have started. You need not to do a complete TAR. It was a RAF hernia. So we have just counted 10 centimeter above because just we want to cover 7 centimeter of our mesh. So this is around 10 centimeter and we have started TAR. The idea is to medialize the defect. You medialize the defect, you go lateral, you cover at least 7 centimeter, and you can see the neurovascular bundle which has been seen beautifully. And then in the same way you do the TAR. I will little bit move faster because I think we are running late. So now you can see we are lateralizing, medializing the defect, and this is the medial part. This medial side space of Regius and Bogras has to be open in lower hernias. So that is the dissection. It's not moving. Yes. So now this is the defect. Contents has been reduced. The bowel was there. And then you close the defect. And in this patient, we had placed a designed mesh. So because this is 22 centimeter in the lower part, and as we have not done TAR in the upper part, so this was the mesh placement. So this is one of the technique of lateral hernia if it is a L3 hernia. Now moving ahead. So these are the patients which we commonly see. I work in a center where many liver transplant surgeries is done in Reliance Mumbai. So you go from the left side, you create a space in the pelvis. Now you are looking from down. So suprapelvic telescopic port has come inside. I'm sorry, I'm too fast, but because of time, I have to be fast because so many processes I have to show. Now you are creating the left retrorector space. Now you're creating the right retrorector space. This is the right side, and now you'll see the defect. Because in liver transplant they use a drug mTOR, and mTOR is known to cause hernia. So now this is the dissection below the defect. You can see the sorry, it is past. So it is TAR above the defect, and you can see the muscular part, lower part, it was more facial than muscular. So this is TAR on the upper part. You'll always see we are medial to the nearest bundle. Now, again, what you have to do, you have to medialize the defect. You have to go lateral at least 7 centimeter to the defect, and see we are creating 7 centimeter space. This was the lateral end. This is the midline defect, and that was the lateral defect. So now we are doing left retrorector space release, and then left side TAR. This is the left side TAR. So you can see beautifully we can go up to perinephric fat, and then we are seeing that we can close that. But the lateral defect was not getting closed very easily. So in this patient, we tried hybrid approach. And believe me, for lateral hernias, hybrid approach is one of the wonderful approach, because patient was having inguinal hernia as well. So both 2 inguinal mesh and 1 large mesh. So in lateral hernias, hybrid approach works very well if you feel difficulty completing with. Now again, see, this is again a patient with some complication of gallbladder, and in this patient, we have done open repair. Now, these are the huge cases where we have used Botox. You can see we are doing TAR in this. This is open TAR, and it's very difficult to go by MIS. And what we do in these patients, we always try to prevent the sac. In all the large hernias, now we try to preserve the sac, and that helps you to close the PRS peritoneum complex. Because in these difficult patients, even after bilateral TAR, you sometimes cannot close the PRS peritoneum complex. So either you have to use vicryl mesh, or you have to use peritoneal sac. So all our hernias, we always try to preserve the peritoneal sac. Now, so again, so you can see this patient, patient with some complication of gallbladder, and see how this is the incision. And when you see the result, this is the result. It is again, in this patient we did hybrid result approach. We did lap. You can see the lap ports as well. And this was a bad scar. And you see how beautifully the output is. This is 2 years after the repair, and it is rock solid. So hybrid repair works very well in lateral hernias. Now, Dr. Ajesh was telling that PTAP is not possible in subcostal lateral hernias. And to me, the indication of PTAP, true indication of PTAP, is lateral hernia. So this is the patient. So you can see the CT scan, and this is the defect. I think this is my last slide, Sindhu, so I'll be quick. So this was the hernia, again, some complication of gallbladder. So in this patient, we have done 3 ports, and the first port is same way as we put the PTAP cranial approach, and then we are going lateral. So we know the falciform trident triangle. If you have a proper knowledge of this, you can be you have to be very slow in these type of patients, and see the peritoneum is so thin. There is no CBD in this area. The only thing which you need is patience. There is no vasculature in this area. Just you have to have patience, and you will complete the procedure. Now you can see the thin peritoneum is there, and we know once we go lateral to the rectus muscle area, anyways we go below the TA transverse abdominis, and that is the same place. So we have done beautifully. We have not done TAR. You can see the TA muscle on the roof, but we have beautifully created a space by this PTAP technique, and that hernia has been taken care of. Now, once we have dissected sufficiently, now this is the defect. It was a large defect. In this patient, we closed in 2 layers, because in 1 layer it couldn't come. Now, first thing, we always close the peritoneum PRS complex first. Sorry, peritoneum first. And if it is not closing, the trick is go more lateral and release more peritoneum than to do anything. I know Sindhu sir has done a couple of cases, and I have seen his videos as well, in which he has used Vicryl mesh. So that is again one of the good technique to use if you can't close the peritoneum in this patient. So we have closed the peritoneum, and we are now inspecting everything everywhere. You have to close all the defects. Even a minor defect has to be closed. Now, this is the defect which has been closed because of the time sparsity. I have just, I'm not showing the closure, but it's closed now. You can see that it's fully closed. And then this is the mesh which we have placed. So for lateral hernias, it's not that PTAP cannot be done. PTAP is one of good procedure for lateral hernias as well. So coming to my concluding slide, lateral hernias are technically demanding due to complex anatomy. Meticulous preoperative planning and pre-optimization is a must. Robotic and endoscopic approach provides superior visualization, ergonomics, and access to the subcostal area. Mesh overlap and fixation strategy must be individualized. So the teaching is, please cover more mesh than you cover in midline hernias. Mesh should go at least 7 centimeters lateral to the lateral margin of the defect. And postoperative pain control and breathing exercise are vital to prevent pulmonary complication. And we know when we do lateral dissection, the ILS is much more than the usual patient. So don't be afraid if the patient doesn't pass flatters in 24 hours. He will pass. And that's about lateral hernia. Thank you very much.
Thank you, Dr. Rajesh, for the wonderful presentation and two very important messages that hybrid technique is very much useful and we must always preserve the sac. So thanks again for that. And now I would like to invite Dr. Kanagvel for his final talk on fasciotense, the new armamentarium for abdominal wall reconstruction, especially in LOD.
Respected leaders of ASI, Professor Shinde sir, and my senior colleagues and esteemed friends across the country and ASI member fraternity. Today I've been asked to deliberate little upon the tissue traction method for loss of domain hernias. I take blessings from teachers who brought into this world of GI surgery and AWR surgery, Professor A.S.M. Chandramohan and Professor Ramana. And friends, I take this opportunity to invite those who are all interested in abdominal wall repair should block these dates to attend the upcoming major international event in Mumbai. So LODs, I will straight jump into the subject. Definitely, these are all not for small hernias. Most of the time when you get to see some patients like this, you please review the earlier repairs. What were many times these patients would have undergone 5-6 repairs. Clinical assessment have to be complete. Please examine the patient in lying down position. Please examine the patient in standing position. And then little bit of adequate exposure is mandatory for you to understand how the folds and how the lie of the hernia remains in different positions. And then a stress CT or a hernia protocol CT is the recommended one for evaluating these patients. And one would have to take more time off in examining the associated issues. Many times you could see fine ulcers, occasionally you could see discharging fistulae, intracutaneous fistulae or intraatmospheric fistulae. So these things are important. These patients are ideally optimized. You can see multiple ulcers which are very meticulously healed. So please exclude associated issues before taking up of large surgeries. This is kindly contributed by colleague from Professor Kelly Slater at Australia. You can see the entire abdominal wall and lying position, how they changes on standing positions. That's the one I'd like to say. These things are important for the anesthesiologist and in the post-operative critical care team for them to handle. When you send these things back into the abdomen, how much of compliance the abdominal wall is going to have. So examining is very, very crucial for making a decision about the surgical treatment. This has been already discussed, but I wish all of you should take attention on the Tanaka's index and the Sabak's index and the CSI, the component separation index, for you to plan a definitive procedure. The myofascial release procedures, which have been deliberated by all my senior colleagues here, it has a steep and demanding learning curve. The requirement is to divide or dissect the aponeurosis, one or more of the lateral abdominal muscles. So that is where tissue traction method comes in. The tissue traction principles remain controlled, sequential, vertical traction of the abdominal wall. It restores the pre-contraction length of the myofascial elements, sustained gain traction length, because once you give the traction, they don't go back to the earlier thing and remain lengthened. And it helps you to preserve the neurovascular function appropriately without any change, and you get a tension-free facial closure. For those who wish to understand more deeper at the microscopic or microphysical structure level, see, generally what happens is take time off for a moment to understand. Once there is a loss of midline abdominal core is disturbed because of this hernia, the collagen fibers, they lose their continuous stress levels and they start becoming crimped. Then what really happens is, moment you start straightening, little bit of crimping gets altered. Then if you see the collagen molecules, you get to see there are, when you going to straighten it, to an extent they straighten, but then eventually the cross fibers do get microfractured. So technically molecular elongation happens to a limit, and then little bit of molecular sliding needs to be happen without damage to a principal amount of crosslinks. So the stress and strain quotient have to be in a controlled fashion. So this was sort of first proposed by Dietmar Eucker 2012, before even the ETAP-RS concepts came in. But unfortunately, it took a longer time for this to be put up as a publication. The first one is done by Professor Jerion Lel. And later, 2021 was the path-breaking year when people started looking upon this as a technique. As of date, we have crossed more than 3,000 applications. This is the global number. And the one big center which has crossed single 100 plus is the Hamburg Hernia Center. All right. Is this for every patient? No. It can be indicated for W3 plus. A minimum of 10 centimeter defect is mandatory, but then it is applicable for all midline defects and all lateral defects. Beyond which, it is applicable for open abdomen in the critical care phase, wall defects in the newborns, and you have the option to apply either open, minimally invasive, or robotic platforms. This I will sum up in one slide, then I'll move on to the technique. Preparation involves very meticulous rehabilitation. We have a MDT in our hospital, which has a surgeon, physician, critical care consultant, and a pulmonologist. If necessary, the cardiologist and diabetologist come in as per the demand of it. Prehab, optimize, Botox them. Botox gives you 4 to 6 centimeters easily when it is done, and a waiting time of 3 to 4 weeks is given. I've already discussed about the control sepsis and fistula control. And then please understand the tissue traction is not the only way. You patient may require potentially additional procedures. So consent have to be for beyond the traction option alone. The gadget orientation and OT-tech adaptation is important for smooth progress of the day of surgery procedure. So for us, the standard protocol for prehab will be increase physical activity, what little possible. If the patient is already doing on physical activity, stress them by another 20% more, or ask them to do the same thing in 20% lesser time. Cessation of smoking, ideally 4 weeks. Cessation of ethanol, similar time. And typically, if they have obesity or the super obesity, one of the standard weight loss options can be considered. An optimal result is obtainable when the BMI is less than 30. Then we move on to one important piece of advice. Many speakers earlier to me, Rajesh Bhai and others, everybody has told about the preservation of the sac. The moment you start incising, you meticulously retain the sac. because you don't know what is in the stock behind for you. So ensure you retain the sac as such as possible, both in laparoscopic method as well as in the open method. This is, I would say, even in, this was the patient which I showed in the principal slide. This was done laparoscopically. As a team, one of my colleagues did this. But then you can see how much of sac can be preserved in laparoscopic method. But then beyond which laparoscopic dissection becomes challenging because of the sac configuration. So that is the case, you make a very small incision, but if you could see so much of sac is preserved for safety reasons, and then it can be utilized accordingly when the myofascial or the traction alone is not sufficient. The steps of the fasciotense remains very meticulous extraperitoneal dissection. If very badly scarred or fibrosed abdomen, a Reeves-Stopa dissection is a minimum mandated one. Tissue traction is essentially intraoperative, and then we have to have the entire set of the fasciotense device. I will explain what are the breakdown of the fasciotense. This is a typical extraperitoneal dissection. You have to be meticulous. Many times you could see this is sometimes very frustrating. You may end up having multiple holes, but be meticulous and close everything. The wound is so much of fibrotic, and more so if you have suture materials, never pull it off in one go. The entire pull of a suture material can tear the peritoneum into full length 2 pieces. So I will recommend very meticulously gentle removal of the earlier suture materials, and then if necessary it can be cut into smaller pieces, rather than all of us have a sort of a habit of pulling when you see the older suture materials in one go. Please do not do it. Please very meticulously and carefully divide, because they work as a knife. Peritoneum is a very fine fellow, and then if you're going to force it, it can take the peritoneum as a 2-piece one. But having done that, as Dr. Sharbai said, once you go into the plane, you have access from psoas to psoas. This is one of the very well done extraperitoneal dissection. Here we are placing a macroporous 50 by 50 mesh all around, starting from the diaphragmatic hiatus to the base of Reeves-Stopa. Here one should be prepared to have a mop, wet mops, little larger ones than the conventional ones. We place a total of 5 mops, 2 on either ends, parieties, 2 on the behind the rectus, and 1 on the midline. So this is important, and this have to be placed prior the traction process is started, because this helps uniformity of the traction and it avoids more peritoneal tears and integrity of the mesh during the traction process. And then the word of guidance for taking the traction sutures. Please desist taking traction sutures along the fibrotic element. It has to be taken on the true fascia, 1 centimeter from the medialmost edge. So we use typically polyfilament number 1 ethibond or number 1 vicryl. Use stitches. Usually you need 6 sutures on either end, and ensure they are equally spread out. Now, once these things are done, we will look upon about the little bit about the traction kit as such. The one what you see on the left side is the traction controller. Then one on the right side is the suture retention frame. I will demonstrate you how to use these gadgets. And then please be aware of the fundamental nomenclature of the components of this device. This is very, very easy to assemble. People who have an idea of Thomson retractor for any other abdominal surgeries will be able to do it in no time. So this is called, the first one is called the screw head post. This is called the post base. And this is the extension of extension rod or the post extension. And you have the screw head extension. And you have an eccentric handle. And you have an articulated arm. Please remember only 4 or 5 things, and most of the things you can handle by yourself without much of a technical help. We recommend you to go through the videos or being mentored by for few cases before starting on your own. So this is how the assembly starts. You can see the post is prepared. You don't need any persons out of a sterile team to have assistance. Ensure The side railing of the operating table is sturdy enough. Sometimes it can be shaky. So please ensure the day before of your operation, the side railings are adequately tightened and they are strong enough. So it's that simple. You start assembling the first bar. And once that is done, you go for the second bar assembly. Ensure before going for the second bar, the screws are adequately tightened and recheck there once again tighten well. And this is the second bar extension bar assembly being done. So once they are done, we go for the traction controller kit along the articulating elbow. You can see there is one, the elbow is loosened. Never unscrew this thing to the full because they have a limitation for the screw beyond which it becomes non-reusable. It's like your hip ball and socket joint. It has to be smooth. So this is too tough. So please undo. And exactly at the right point, if you keep, it becomes so easy. That should be that easy. This part is done. This ideally should be done at the summit of the defect. So equidistance from up and down, equidistance from lateral to lateral. Then we move on to the next step of instrument assembly or the cartridge preparation. You have already taken 6 sutures along the facial end. This is like a snap fit device, which is very, very easy to learn. All of you know when you are electrician or the the distribution board people have sequential clips for understanding how they are going to, like A1, A2, A3, like that, they have clips. So same method is being adopted and the gadget is ensured it is freely moving. Then you start attaching the thread to the carrier. Thread which is taken, the stitch which is taken on the right side goes to the left side, and the stitch which is taken on the right side goes to the left, and to the left to the right side. If you could see, you can see which is seen on the other side of the abdominal wall comes to the ipsilateral side. So the contralateral stitches go to the ipsilateral, ipsilateral goes to the contralateral. So it is that simple, and we always use an additional hemostat for securing the thread. Always start from either ends, the uppermost and the lowermost, and come to the summit. This is not difficult at all for anyone to understand. Once you see, you will be able to do by yourself. It's not a difficult technique. The instrument part of it is very, very straightforward. And once you complete this process of attaching all the thread, I will tell you, we normally start with 8 kilos of traction. Usually 8 kilos traction, we give 30 to 40 seconds compression. People recommend up till 2 minutes also. But ideally, the recommendation by the fascial-tense team will be for 30 to 40 seconds. And you give some time gap in between. Then once you do it again, the process is repeated at the ideology of 2 kilos at a time. At a maximum, do not exceed more than 18 kilos. So 8, 10, 12, 14, on that basis, you keep going. And once this process is completed, every 2 kilos, you may need to retighten the threads because the traction helps the threads to become loose as the tissue gets more and more lax. Do not forget to remove the mopping pads. Very, very important. On removing the mopping pads, you gain another 3 to 4 centimeters. It becomes a formal closure. Please do not use this ethibond or the vehicle for closure of the abdomen because these threads have gone weak because of the continuous traction stress onto the thread. A typical standard policy-based closure of how you close the abdomen is what is needed. We always recommend to place a drain in the peritoneal cavity, as well as the more adhesion lysis you have done, it is safe to keep a drain over there. So this done, the closure remains straightforward, and then your operation is done. So let us see how much of defects we have closed. At this point, In our center, we have closed maximum of 32 centimeter defect. But then people who would like to have evidence, the evidence says the 95% of closure of defects up till 15 centimeters, 79% closure of anything up till 19 centimeters with the assistance of Botox. The rest require, that is more wider defect, always require an additional procedure in form of a limited component separation or one-sided component separation or bilateral extended component separation. So please be prepared. The tissue traction component can be applicable up till 15 centimeters. Almost you will be successful without any additional procedures. But if it is exceeding more than 19-20 centimeter, you need to be prepared to handle this. This is one of the very recent publications where they showed how the size matters. So if you could see, none of the cases of less than 8 centimeters have been taken into this study group. A very well randomized group of subgroup 1, 2, 3 of each 45 cases. This publication was from February from the Hamburg group. Then people may ask, is there a data behind it? Are they done adequate cadaveric applications? Yes, at this point of time, the limitation of the traction remains 22 kilos max, but then the 30 kilos or 32 kilos of the breakdown where the fascia can get disrupted. So the long-term outcome and quality of life data are coming in for you to get more and more confidence. This is open access publication. You can, all of you are interested in AWR, especially the tissue traction method, can download this Hamburg algorithm, very recently published, where a very well done size-based, especially the LODs have been categorized, and where exactly the intraoperative facial traction device comes in have been very meticulously marked. This is a very useful thing for youngsters and beginners of this procedure. So ladies and gentlemen, to sum up, benefits of the intraoperative facial traction: utilize the myofascial elongation property of the abdominal wall. It produces quantifiable standardized traction. There is no requirement of traumatic tissue dissections or violation of neurovascular bundles. It conserves the anatomy and all the functions of both the abdominal wall and the respiratory functions. Those who are interested in getting into more information or more active deliberations of open abdomen or these type of tissue traction procedures, who are interested can scan this QR code and join the group wherein you can deliberate about your own difficult cases and the entire globe deliberates on this platform. Thank you for the attention. Thank you very much for the opportunity given.
Thank you, Dr. Kanagvel, for the wonderful exposition of fascio-TENS, its academics, and actual technique of how it is done. So I think we have shot above the time that we normally give, but I think we can have 2 or 3 questions. A very pertinent question has been asked by Dr. Chandrasekhar, Professor of Surgery from Tumkur, that what are the contraindications for ETEP? I would request Dr. Rajesh Srivastava, who's got a pretty fair experience in doing ETEP reeve stopas, to take this question up. What are the contraindications for ETEP?
Thank you, sir. Of course, it's a very important question. So before we discuss the absolute and relative contraindication, one of the contraindication is if you know this technique, you should not apply to all the patients. Number one, that is very important. Because we have seen so many complications. Surgeons are doing 2 centimeter hernia, 3 centimeter hernia with ETEP, and that should be very serious contraindication, and that should be very serious teaching to all the beginners. Second, coming to the actual answer. So the absolute contraindication is if the patient is unfit for GA, you cannot do ETEP. There is no second thought about it. Patient is having strangulated bowel, you cannot do. Patient is having gangrenous bowel, you cannot do. Peritonitis, intraperitoneal sepsis, you cannot do. Apart from this, there are relative contraindication, and every surgeon should know their limit. One should not try to do ETEP TAR in a patient having not having experience of simple hernia, and he should not enter into the hernia where 14 centimeter incision hernia is there. So relative contraindication can be multiple previous scar, previous mesh in sublate plane, patient has been operated by open technique or whatever technique in sublate plane. There is obstructed hernia. Even there is no strangulation, a beginner should not try. If there is severe obesity, say for example BMI more than 40, and then patient has come to you, so one should not. But these all are relative contraindication. One may say that I can do it up in these patients, but yes, these are relative contraindication. And we have discussed so many times. You have also said, Kanagwal sir also has said, hybrid procedure is wonderful procedure for these difficult hernias. I am telling about myself. I am very good in doing lap TAR, but when it comes to open TAR, it is not that easy, because the magnification you get for TAR, and then once you have done TAR, there is no harm in giving incision on the scar, taking out the scar, and then doing rest of the thing by hybrid technique. So I think if somebody can add to this, I am happy to for that.
Thank you, Rajesh. I was wondering whether incisional hernias, whereas bowel is stuck, and in an E-tap Reeve-Stopa, we are relatively blind when we open the sac. So would you want the young surgeons to venture into incisional hernia with bowels in the defect?
So that's why I said, sir, it is all these relative contraindications are experience dependent.
Okay.
Now, whenever you go for a hernia post IPOM, you are 100% you will get adhesions such as bowel and all. So the trick is we all know hot dissection and cold dissection. You always should use scissor. You always go from the area where there is no adhesion. So these all are tricks which one would learn in the practice. But of course, you are very right. For a beginner, you should be very careful, because one nick in the intestine will ruin your hernia surgery. And especially because if it is colon, then none of us will even dare to place a mesh in that situation.
Thank you. Thank you, Dr. Rajesh. Dr. Ajesh Gopal, you do a lot of ventral taps and extraperitoneal procedures. So what kind of an ideal patient should one choose to begin to venture into these extraperitoneal repairs? Do you think all patients are equal, or some of them are easier?
Sir, actually, is it about the all the ventral hernias or midline ventral hernias?
Midline mainly, ventral tap or a P-tap if you want to venture.
Yeah.
Should we choose a very skinny patient, a very obese patient, or what kind of patient will be a little easier in the extraperitoneal repair?
Yeah. To start with, earlier it used to be a ventral TAPP, sir, to start with. Now, 2025, 26, people are thinking about the PE-tap also.
Yeah.
Two options, the cranial approach as well as the caudal approach. Myself, I am comfortable with the cranial as well.
What type of patient would you choose? A thin, skinny patient, would it do, or you would want him to be a little obese or something like that?
Either way, sir. Obese patients also, we can undertake PE-tap.
Okay.
Only thing is, it is not my go-to procedure for the lateral hernias. Dr. Rajesh was doing lateral hernias with PE-tap. Okay. My go-to procedure is ventral TAPP, E-tap, then PE-tap for laterals. Midlines, definitely, as of now, PE-tap. Ventral TAPP. More than 4 centimeters, definitely I'll go for E-tap only.
Thank you. Thank you.
Sir, just a comment to your question. Whatever experience we have seen that male patients are best patients for this P-tap repair.
Okay.
Yeah, they have very good peritoneal quality.
Because we know the concept of visceral fat and subcutaneous fat. We know the concept of gynecoid obesity and android obesity. Android obesity are best for these P-tap repair because there will be some fat on the peritoneum as well. In females, if you take P-tap, be careful. And when you are doing P-tap, always take a consent of second procedure, may it be E-tap or may it be IPOM. That is again a lesson for the beginners.
Yeah, I agree with that.
Thank you. Thank you. Thank you, Dr. Rajesh. Dr. Raj Gopal Shiraya also had a very pertinent question of, does this tissue traction produce any tension? And I think maybe he can ask once again. We are also concerned about the abdominal compartment syndrome or a raised intra-abdominal pressure. So Dr. Kanigvel, what is your take on how does the abdomen behave pressure-wise in the tissue traction?
Very, very important question. Sir, as long as we are maintaining the sanctity of controlled traction, the controlled traction word means 2 kilos every 2 minutes on that grade. Generally, there is no immediate rise in the intra-abdominal pressure. But
Okay.
then we have to keep the anesthesiologist to understand the peak pressures. The
Okay.
peak plateau pressures have to be understood. The anesthesiologists have to be pre-procedurally, before even you start the case, once they are intubated, before starting the case, ask them to measure the peak pressures well. On traction completion, generally 6 millimeters of mercury. That is what is permissible. Beyond, if it is going for 6 mil, like it grows to 10 millimeter, at the completion of the traction, it should come back to 4 millimeter or 3 millimeter. If the pressures are after completion of the traction closure, if the anesthesiologist wants you that your peak pressure increase is more than 10 to 12 millimeters, then you're going to be in trouble. Either you're done the traction too fast, or the traction and closure, what you have done is too tight. So you may require some form of release procedures at this point of time itself. But generally, the P-plat and the peak pressures are the one which helps you to understand whether the patient requires only intraoperative facial traction or an additional procedure. This is a very important help by the anesthesiologist, which helps you to decide your procedure is ideally singularly sufficient or you need some additional release procedure. Thank you very much, sir.
Okay. So thank you, all my panelists. So our esteemed guests here, Sir Dr. Rajgopal Shenoy, sir, would you like to have any final comments?
Nothing, sir. Thank you very much for your excellent webinar. And I also appreciate it is the mastermind behind this, Dr. Santosh John Abraham, who has selected every one of you, and you are all, each one of you are stalwarts in your in the society, and such a fantastic webinar with the videos, and I really thank each one of you, sir. That's all from my comments, and there are few other questions. I think most of them you have answered, like preoperative optimization and those things. That's also one of the questions which was asked. I think you have given answer. Thank you, sir. That's all from my side. I appreciate it.
Thank you.
Thank you very much. Request Dr. Reddy Devagar to say a few words.
Thank you, sir. Good evening, everyone. Rather than going at length, so let me briefly say that I would like to place on record our sincere appreciation for the moderator, Dr. Pramod Shinde, sir, and all the distinguished panelists whose vast clinical experience and practical wisdom has greatly enriched this session. And definitely their insights are drawn from years of their surgical practice have provided valuable guidance to us young surgeons across different levels of experience. And I also thank all the participants and look forward to their continued engagement in surgical learning. Thank you all.
Thank you.
Thank you all.
Thank you very much. I would like to have Dr. Madhumita to say words of thanks, word of thanks.
Thank you, sir. This topic was a very important topic, and it was explained so well. At the beginning, our thanks to our President, Dr. Marzupandian, our Vice President, Dr. Varute, and our past President and our Academics Director, our past President and our Social Service Director, Dr. Siddesh, for all your inputs on this program. Thanks to Dr. Shenoy, our Director Academics, for planning this program, and to our academics advisor and past president, Dr. Santosh, who is the whole architect behind this whole program. Thank you all, sirs, very so much. Thanks to Dr. Pramod Shinde for a wonderful moderation, and to our panelists, Dr. Ajesh, Dr. Sharad, Dr. Rajesh, and Dr. Kanagabel, for your explanation of this whole topic in such a lucid and such a wonderful way. Thanks to our secretary, Dr. Gaddi Divakar. Thanks to all of you, all the members who have been watching this program. Thanks once again. Long live ASI.
Thank you very much, all the people. Good night. So it's a
Good.
little bit
Thank you,
late.
sir. Thank
We
you,
have
sir.
seen a good exposition. We'll meet next week the same time.